So Carlos, Felipe, Odin have given really excellent examples of the applicability of AI in many different facets of modern life, from personal finance we just heard to making developers more productive, customer-facing products. And we're now changing gear to talk about something that obviously makes us all human, which is our health. And AI in healthcare is kind of a mixed bag of a story. Overall, when you compare different sectors of society, healthcare has not benefited as much from digitization as many others have. There's lots of reasons for it that we could probably talk about for hours. But mostly over the last few years, we've seen that if you go digital in any meaningful form, certainly with the application of AI, productivity increases and your costs decrease. Healthcare, strangely enough, is the outlier where productivity is actually stagnant and often decreasing, and costs tend to be at least 2% above the rate of inflation. It's a very different sector from all others. However, it is one of those where AI has early been tagged as the perfect use case. And within healthcare, the original use case that people talked about as early as in the 1990s was radiology, because you have an abundance of what we just heard from the other presenters of data points. Because if you take, for instance, X-ray images, hundreds of millions are taken every single day in all kinds of different settings. So you can train an AI very, very effectively on those images. And why is it maybe a good idea to do so? I'll just talk about a little bit here in a very specific case. If we go to the next one, it's a case that is universal. About 2 million women every year get diagnosed with breast cancer. And if we look at what makes the difference between in survival rates, there are several things that have to come into play, but one of the factors you can inflect is the stage at which it's detected, and that's ultimately where the AI comes into play. If we go to the next one, all industrialized economies have more or less implemented screening programs where women that are eligible in a certain age group will be invited to go and participate in screening, which usually consists of 2D mammography, meaning you have an X-ray machine and they take 4 images, and then you hopefully are in a position, if you do this regularly enough, to catch any breast cancer early, because the odds of survival flip dramatically depending on whether you're in stage 1, 2, or stage 3 and above, because ultimately it's more treatable. So what you want to do is you want to find it early, since you can't very easily prevent it, at least not in ways that are currently available to us. So mammography screening is something that's been implemented. All of the countries that are represented here on the call, as far as I can see, have public programs on this. Now, here's the issue. If we go to the next slide, you're doing essentially a check on a population that is asymptomatic, right? You're not going to a screening because you're sick, but you want to stay healthy. You want to find something early. And if the screening is done well, and here's the example of Mexico and Sweden, if the cancers are found early stage, then you have really excellent odds. And if it's found late stage, then you don't. But that means you have to take millions and millions of images onto the next one. If you think of this as a cognitive task, because that's what AI is meant to help with, right? Human beings, we are arguably all in cognitive overload, but if you put yourself into the position of a radiologist will be looking at 4,000 images and 1,000 women, and there will be no more than 4 cases of breast cancer in there. So you're looking at a lot of images where actually there's nothing suspicious to see. So you have to work through a mountain of data and information. That's why radiologists have to train highly. And in particular, breast radiologists have to do thousands and thousands every year just to stay certified. So it is the perfect example of the needle in a haystack, where the human really struggles to keep up with it. Now, in Europe in particular, of course, we have aging populations. That means the number of people that are eligible of women for breast cancer screening is increasing. We're also seeing developments in other parts of the world where the age at first presentation is actually decreasing. So overall, the pool of women that should get screened is increasing. But obviously, what isn't increasing is the supply in radiologists. When you're looking at sort of the average age for you that are located in the UK of a radiologist, you're looking somewhere north of 50, which means at some point in the future there just simply won't be enough people to do screening, especially since in Europe we do a double read, meaning you have two radiologists independently read the same images and then they have to come to a conclusion. If they disagree, they have to come to a consensus essentially. So you have two people looking at those same images. At some point that's not going to be feasible. So from an AI point of view, one, you've got a plethora of data, all those images. Two, in order to maintain and hopefully improve the services that we're delivering, you at some point won't be able to do that without AI. But at the present moment, everything in life is about timing. It's still sort of kind of working. If we go to the next one, the idea behind it is that you essentially go to the screening. It could take place anywhere. Our particular technology, and many others are similar, but not all of them, is cloud-based. That means you can have the scan taken in one location, but the image can be read in another. And then you maximize ultimately for the speed with which those images are read and the precision so that you can find more cancers. And our AI algorithms make a prediction. They are coupled with a viewer, which essentially you can think of a workflow tool that combines all of this information so that radiologists can plan what they're going to do in the next hour or so as they go through those images. And we make predictions where we say, look, 80% of these images here, our algorithm is highly confident that there's nothing suspicious. There's not a lesion that you should investigate further, but we are very clearly a human in the loop type of approach because in healthcare, you do not have machines make decisions on behalf of humans. So we are a decision referral tool, meaning it's like an extra set of eyes trained on 11 million data points that is helping you make sure that as a radiologist, you can bring the best of your professional judgment, combine it with what AI does best, which is to use huge data sets and to be highly precise, combine those two then to come to a decision so that we can say those 80%, maybe you can look at them later. You don't have to look at them nearly as much. In 20% of the cases, essentially, there's something potentially going on where we would argue you need to spend more of your time on it. If you go to the next slide, and if the radiologist looking at it makes a different determination from our AI essentially pops up and says, you might want to consider this particular location. You know, maybe you're thinking this is benign, but we actually think it isn't. And then, of course, the radiologist can still decide to overrule it if they want to. But it is the nature of healthcare that you've got data sets that are usually fragmented, but in the case of the German National Breast Cancer Screening Program are actually longitudinally available. So you can actually track where the AI made a decision made a suggestion, not a decision. The radiologist made a decision, how they incorporated the AI into their decision making, and was it right or wrong? I mean, that's ultimately the beauty of when you have sort of this sort of technology is that you combine the best of the human professional with the technology, and then you can look back and say who was right, who was wrong, and what did we do together that couldn't have been done if we had done this on our own purely as humans. If we go to the next one, we can look a little bit at just very briefly at what that ultimately can look like, because we look at breast cancer screening not as an event, something that you go to, but it's actually a process. You have to be invited, you have to have an appointment, there has to be a radiologist, there has to be a technician who actually does the scan. There needs to be data collected. So what we always talk about in healthcare, it's a pathway. There's a clinical pathway from beginning to end. And if there is something, some suspicious lesion, it needs to be investigated through further imaging, potentially through biopsy, and then you have referral into treatment. The argument that we're making is all of this can be enhanced through AI. You can have a much faster screening process, you can have a more precise one, and you can improve your performance over time for the benefit of the population you serve. And in most countries, the population you're serving are women in a certain age range, often between 50 and 69, when they should be having this done unless they have a family history every 2 years. Just very briefly, looking at what is the impact of something like this? What can you do clinically? If you go to the next slide. What you want to find is more cancers. So healthcare is the ultimate home of credentialism. Everything that we do, we need to be able to prove in peer-reviewed and evidence-based journals, essentially, where we're working with academics to make sure that the claims that we're making are correct, because our AI is a medical device. So it's certified as a medical device. It's not just something that you can plug in and run with. This is the sort of thing where regulatory agencies come into play, which I think it was Orun at the beginning where he was talking about bureaucracy. The complexity of integrating something like this increases tremendously when lives are at stake. This is not just about, me finding, a fun toy online faster. This is actually about somebody who needs to know, am I okay for the next 2 years, or should I be worried? So top left, find more cancers. Essentially, the 50% here means when you have the two radiologists I mentioned, if they come to the decision there's nothing to see here, in many cases, there is a cancer that could have been detected. And we find 50% of those cancers that could have been detected. Why does it matter? Because in the interval between two screening episodes, that cancer can develop. At the same time, though, you don't want to increase the rate of recall, which means women will get called back and say, we found something suspicious, we need to investigate it further. For the majority of them, it will turn out to be nothing. But of course, it causes enormous distress psychologically, but it also is a cost to the system. And for healthcare, where like the US is spending 20% of GDP, you need to look at the inputs and the outputs. So if you have a technology like this one with AI, you can say, we find more cancer earlier, it's more survivable, and it's less expensive to treat. And at the same time, you're also decreasing the number of follow-up exams, all of which cost money. Then you're finally finding something that is not going to lead to healthcare inflation. And at the same time, you can do this faster, which is the workload reduction. So ultimately, what it amounts to is, in this particular use case, you want to find a way to meet the needs of all of the constituencies. The women that are participating want to have this done quickly and with high precision. The radiologists that are doing breast screening radiology want to always improve the way they perform, and they need to keep pace with the volume of images that need to be processed. And the healthcare system hopefully will be able to do this at a sustainable cost. And that is roughly how I would submit to everyone here then, is actually not just a healthcare thing, that is a universal model for the application of AI in any sphere of life, is that you need to maximize for the number of constituencies and stakeholders whose KPIs you can meet in however you apply it. And I think that's where I'm going to stop, because I know we're actually officially already over time, and happy to take any questions.
No questions from me, just to say thank you for doing what you do. And this is a great application of AI.
Thank you for saying that. Much appreciated. And I will pass it on to the ML team immediately.
That's brilliant. Thanks so much, Egbert. Are there any other questions from anyone else?
We actually had Egbert, we had a in the UK TAI event, we had a UK business who have a similar kind of use case for this technology, and it was yeah, I must admit, it was a very it's quite a lively debate. I think this is obviously a subject which touches lots of people, but I think the bit that you quite interestingly articulated, perhaps more so than our UK event, was this is an assistant to to the practitioner who's running the appointment, and this if anything kind of helps to helps to either flag something or increase the likelihood of something being scoped out, as opposed to something which is trying to replace any practitioner who's obviously conducting the examination. So yeah, quite interesting to hear the positioning actually, and how it differs from the UK event.
And I think I can anticipate, Jack, thank you for that, is the second reader, the NHS is looking into replacement. So we are talking about actually replacing a human being with an AI. Now, there's still, the way it's going to be implemented is the decision-making will still be with the radiologist, but there may not be a second radiologist, because the evidence base is converging in such a way that the AI can do an awful lot. And it's just down to medical ethics. What will people accept? This is one of those spooky elements about AI where people get quite nervous about, humans being replaced. And what could be more sensitive than human health as an area where you having AI making a contribution that is possibly larger and more impactful in your life than maybe it is in personal finance. So yeah, there's much debate to be had, and I think people are not quite ready yet to look into replacing people entirely.
And I guess just on that, it starts with an idea, of course, and then a proof of concept, and then some meaningful data and some application. But you're also entering, particularly in the UK, as a good example, like an incredibly fragmented and historical legacy kind of chain of systems and applications and software, which you need to try and navigate and enter from a product fit perspective as well. So I guess in terms of that real life application of this stuff, it's all very well kind of maybe cracking this as we think we can do something here, but how have you found from a business perspective the actual the ability to then go and implement this in a scalable way?
You have put your finger exactly on it, because in healthcare, nothing is a green field, right? Some of the other examples that we heard on this fantastic event, you're just doing it for the first time and people are happy to embrace it and just run with it. But in healthcare, of course, you have people already doing mammography. They are using software to read those images. That software is integrated with, as you said, Jack, legacy systems. There are EHR vendors. There are picture archiving systems. There are radiology information systems. And then, of course, there are public health systems and databases. And in order for this to become viable, you do need to find a way to integrate them so that this all fits together. And I cannot imagine a landscape more fragmented and more also beholden to legacy technology, that some of you would just absolutely be astounded as to how old some of those systems are. And now you come through the door with an AI system that is cloud-based, and absolutely nobody in that hospital has ever used anything cloud-based other than Microsoft 365. So you're putting the finger on it. It is no mean achievement, and that is actually what has been limiting the scalability of all AI products, especially the cloud-based ones. No matter how easily you does it, ours is actually literally a browser extension, so that you can just, there's not even much installation required. There is some required with the machine itself, the X-ray machine, obviously. But it is actually one of the things that's been holding it back, because those legacy systems that have been around for 30, 40 years, they really keep a lot of healthcare providers in what I call Babylonian captivity, where the ability to integrate something new is actually something that can be used for squeezing more revenue out of people. I want to be very careful what I say here, but it's one of the many reasons, like I said at the beginning, why digital transformation in healthcare has not been as rapid and not as powerful and impactful as it has been in other industries.
Yeah, well, yeah, good to have an honest answer, right? Yeah, it's a challenge.
Yeah.
Thanks, Egbert. Very, very interesting. Carlos, I think you raised your hand actually while we were chatting.
Yeah, first, great presentation, and it scared me that like healthcare is like a little bit behind on this accepting this concept, because it's one part that you have more reliable data in general, like the amount of trials, tests, consistent data is there, and this is really game changing in that scenario for AI. Having a certain information most of the times, like more than anything else, is like where we can make a huge difference. But as you said, there's the human paradigm over this. People are afraid of what involves their life, so literally life, so trust. It's a little bit more complicated.
You're absolutely right, Carlos, and I'll just say to that, because I have to be careful about what I comment on now, but it's all about incentives, isn't it? And in healthcare, the incentive structure for the adoption of new technology is very different from other industries. Everywhere else, there's a certain purity about, can I bring in more revenue? Can I be more productive? Can I add more quality? But in healthcare, of course, it is the one industry where none of us actually directly pay mostly for our own services. They're provided by somebody else. Then you have a third-party payer. The third-party payer actually needs to decide this is worth paying for, and this is where you get to the subject of reimbursement. You can bring tremendous innovations into healthcare, but unless an insurance company or a government says, we want doctors to do this, requires a regulatory change, clinical practice guidelines, reimbursement tariffs. It has many layers of complexity to it, and that's why the innovation cycle in healthcare, despite all the tremendous improvements that we've seen, is actually really slow compared to other sectors.
Do you think that this is more challenging in Europe, where we have more like a concept of public healthcare than like in US, when you have private healthcare and they have to invest more money?
In general, I try to deflect that question because when people start comparing healthcare systems, I always say, you know, most nations have the healthcare systems that are most congruent with the values of the people that created them. If America is a place that is a bit more fleet of foot, where people are happy to experiment, it is because the nation prides itself on rugged individualism, entrepreneurialism, and ultimately an approach to life that is radically different from, say, Sweden, where you're absolutely right, or anywhere in Europe where you have a very strong social responsibility component and also collectivism to the way healthcare is organized. That's why we have often single payer systems or other arrangements, whereas in the US it is. So is it fast in the US? Absolutely. Do these things get adopted more quickly? Yes. But the US also spends 20% of GDP on healthcare, increasing. Is that sustainable over time? Not entirely certain, but ultimately each society needs to decide what is the paradigm that governs our healthcare system, because healthcare isn't like other commodities. It is foundational to life. Some people would even regard it as a human right. Therefore, those things become much more difficult to arbitrate than the adoption of technology in retail.
Okay, thank you.
Luis, should we have one more question, Luis, and then we'll wrap up. Aware that we're over time, so thanks everyone for hanging around.
Okay, it's very short one. Thank you for our presentation. I have just one question about, like, could it be possible, not so much about AI, but about this part of health part, could it be possible to blockchain and also mobile device bring some advances in this area? Like I worked in the past in a POC or POC that brings together the health system, the patients, and the labs, and blockchain like takes care to not have like wrong shared data, and also the patient authorizations to the doctors can see the exams and everything. And maybe here, like thinking about this huge amount of images, would it be possible to have a mobile device that bring more data and also spread more, like today in poor countries, people take 6 months to get a screen breast exam. So like how do you see the improvements in this, like bring together not just AI, but blockchain to take care of the data and mobile devices to spread increase a lot of these numbers of exams? Thank you.
Yeah, absolutely, Lewis. Thanks for that question. And you've opened up a big topic. I think to do it justice would require probably more time than Liam and Hope are willing to give us at this stage. But without question, the infrastructure that we've built in the West is highly expensive and quite clunky. And the trend is actually to getting closer to where the individual is. Therefore, blockchain and decentralizing things and putting it in people's hands is a trend also in healthcare and AI in healthcare that we have seen, including in areas like, screening for tuberculosis, screening for breast cancer, even handheld devices, using smartphones. There's always going to be a trade-off in the amount of in what you can do and what you can prove clinically, because ultimately the stakes are so high in healthcare that you need to make decisions about what is going to be clinically effective. So to give you an example that speaks directly to your question, there are people who have developed AI that can use a smartphone to take a thermal image of a woman's breast to see, create a heat map, essentially, because where you have a potential lesion, the blood vessels change and therefore more heat is generated. That's one way you can approach it. Others have developed AI that can work with handheld devices like ultrasound. We have focused ourselves on mammography. Then, of course, you've got 3D mammography, you've got MRIs, you've got different levels. The question in healthcare you always have to ask is, well, how can you meet the greatest need of the greatest number of people? And what of that can you prove actually is going to make a difference? So when it comes to our field, for instance, the only modality that has been proven to reduce mortality is mammography. That is why we are focusing on that. But we know fully well that in many parts of the world that is not going to be feasible. You have to probably stratify the population, where people who have access to mammography, who live in more urban centers, will potentially have access to that technology, whereas other things, mobile vans, handheld devices, would have to be in outlying areas. It's a discussion about ethics and philosophy that will be propelled forward by things like blockchain and handheld devices. But the burden of proof in healthcare is just incredibly high because you need to be evidence-based. You need to be able to prove it. It requires years of research, and not everything can actually be proven quickly enough to meet people's needs. So there's a lot more to come, and potentially the way we're doing it right now will be superseded by rapid innovation in places that have fewer resources and therefore had to be a lot scrappier in how to get to the finish line.
Thank you.
Okay, Saraf, you have also raised your hand. I did say Lewis is the last question, but is it a quick one?
Yes. Hi, thanks. This is really interesting presentation. Yeah, you briefly touched on, healthcare systems with scrappier resources. And I was wondering, how does that link to, well, I guess, how, in your experience, how have doctors and radiologists reacted to AI tools being used? Are they promoting it? Are they sort of resistant to it, or are they skeptical of it?
Well, that's a really fantastic question. I'll try to be brief about it. Of course, it is a mixed bag. You will have, especially younger generations of doctors generally, are much more embracing of this technology. But if you're looking at the average age of most clinical practitioners, they'll be in their 40s or 50s. They will have a different perspective on this. There's also this issue of people might feel threatened by it. Am I being replaced by an AI? We find that actually rarely, but clinicians have a huge pride in what they're able to do, and rightfully so. They invest, 15 years of their education in getting to where they are. And sometimes we talk to radiologists who say, I'm better than your AI. I'm faster than that. I can find it just as well. And you know what? In some instances, that may be true. But of course, that's not how the world works. We want every radiologist, not just the one who does 50,000 mammographies a year, also the one who only does 5,000, to be as good. And the only way you're going to do it is with the help of technology. And I think overall, the evidence is so conclusive by now, not just from us, but from all other organizations that are deploying AI in imaging, that we're winning the argument the way arguments are won in medicine generally, and that is through the evidence base. It's through the credentialism. You're doing great research with great universities and academic leaders, and ultimately this is a science-based sector of our society. That evidence base wins the day. It just might sometimes take a bit longer because the hesitancy is greater and the bar of proof, the burden of proof, is higher.
Got it. Thank you.
Thank you, Derek. I think that concludes. Thanks, Liam, for organising the event, and thanks, Felipe, Egbert, Honor, and Carlos. Awesome talks and very different perspectives, which I think is the key thing for us. We want a diverse panel which can kind of bring a different perspective on this thing, on this kind of beast that is AI, and the lens that you all have on it. I think we've nailed it today. So round of applause, virtual round of applause for everyone. Thank you very much. I guess from my perspective, just to help wrap up, we're very fortunate that we get to hear this stuff from not only the panel today, but equally on a daily basis from the customers that we're working with from a talent perspective and the candidates that we're also working with. So we're hearing, I hear the extremes of, we're at the point of a paradigm shift, and software engineering as we know it is going to be a thing of the past, along with the opposite, the opposite of actually, this is just a blip in our history, and yes, of course, it's going to impact us, but actually fundamentally cut through the noise, and life will continue as we know it. I think our ongoing advice is let's continue to observe this. I think don't get caught napping seems to be the advice we're giving to most. Make sure you're upskilling and you're knowledgeable and you're using AI in various different ways, from even as basic as ChatGPT, to help assist you and automate your workflows, but in a way where actually, we're very cautious, and that we're not kind of following a trend, and there is a new world emerging where actually we're seeing for the first time new positions being created that haven't existed before. So the governance of AI, and how do we actually create the playbooks and the frameworks that enables our workforce to leverage AI in their daily work. In a safe and secure and consistent way. These roles didn't exist before. So for every job that maybe that something is able to kind of automate or replace, we firmly believe that actually there's a slightly different skilled workforce that will help take us forward. But it's all new, and there isn't a CEO in this planet right now who isn't asking their business to start thinking about AI or throwing money into AI or building new teams. And that's why I asked Carlos around the kind of academic AI kind of profile versus the software engineer profile, and how we get those two kind of those two personas, I guess, to kind of successfully kind of work together. And equally, we're seeing that from a product perspective. We're seeing AI product managers, as a new role coming out of all this. And actually, is that AI products for how we're using it in a fintech space, like Plum, and how do we build AI into our product feature to our customer value, or how do we use AI as a pseudo product owner internally, and how do we start to create a product roadmap for the adoption and products that we're going to use for internal AI? So, I think it's a rapidly evolving space. These sessions are super insightful because it gives us visibility and perspective. So thank you very much, everyone, for attending. I appreciate it. There'll be a follow-up afterwards with all the content and any connections with speakers and panelists, etc. But other than that, I think that's a wrap. Thanks, Hope. Thanks, Liam, and thanks again to the panel.